Jackie. That was fantastic. And now our next presenter is Dr. Norman Silverman, who, as you know, is professor of pediatrics and honorary faculty emeritus of pediatrics at Stanford University. Has had incredible contributions throughout his life in the area of imaging, and especially Ebstein's anomaly is one of, he has a passion for this disease. And he'll be talking about echocardiogram insights on Ebstein's anomaly. Dr. Silverman.
Thank you, Jackie. Let's see whether this is working. Good morning. Is there a microphone? This is it. Thank you very much for having me here this morning. I just need to make sure that I get this in play mode. I really am very grateful to the organizers of this symposium for inviting me to address you. And I figured that I would look at this session from the point of view of what does an echocardiographer do when he looks at a patient for the surgical procedure that the De Silvas have pioneered. So let's just have a look at what Ebstein's malformation really is. On the left-hand side, you can see a beautifully normal tricuspid valve with the right ventricular body removed. You see the anterior papillary muscle, APM, the septomarginal trabeculation, the parietal band of the crystal ventricular and infundibular folds, and you see the attachment of the median and anterior papillary muscle, subtending both the septal and the anterior leaflet. When we look at an Ebstein's, and we look at this from the right ventricular apex in the same way as we looked at it in the normal, you can see the variability of the Ebstein's valves related to what you see with the echocardiogram. And in fact, there's fusion between the anterior leaflet and the septal leaflet, as you can see, and a so-called keyhole orifice that we see here. My mouse seems not to be working. So that's what an Ebstein's malformation looks like from the ventricular aspect, an aspect that is not often seen by the surgeons who operate through the atrium. This is a patient of mine, the first patient on the left-hand side, who by the physiologists deemed that this right to left shunt could be managed by closing the atrial septal defect, whereupon within an hour of this closure, the patient succumbed and died. And so we have his heart. And what this looks is the surgical view of the tricuspid valve. And you can see the tricuspid AV junction here. It's not an annulus. And you can see this progressive displacement of the septal leaflet, which is done in green, going down to the junction between the septal and inferior leaflet, which also appear to have fusion on them. And this stays that way until we get round to the anterior leaflet, which is normally placed. On the center area is a picture of how an echocardiogram would be done on the right, and shows the positions of the right atrium, the atrioventricular junction, and the atrialized and functional parts of the right ventricle. And Dr. Christian Schreiber, in looking at 27 of these defects, put in the position of the atrioventricular junction and annulus and valve in these positions. So we can see that there's progressive displacement around this hinge point of the tricuspid annulus. And here on the right is an echocardiogram in a subcostal coronal cut, which shows a number of these features. First of all, there's pulmonary insufficiency, part of a circular shunt. The tricuspid valve jet originates within the right ventricular outflow tract. Here is the true atrioventricular junction. And here we can see from this the perpendicular shunt coming down towards the diaphragm here, an unusual position for tricuspid regurgitation. And this indicates where the atrioventricular true valve junction is situated. Let's just go back a little bit and look at the embryology of what happens. On the left-hand side, at 8 weeks of gestation from the Carnegie collection of embryos is a section of a normal tricuspid valve. And at the end of the embryonic period, the valve shows only an anterior and septal leaflet, and as you can see, there is no delamination of this valve from the septum. And this is what happens in Ebstein's malformation, because as the delamination occurs, the valve is freed and is situated in its normal position to the annulus later on in gestation. In the center is a new way of looking at this from a paper by Hicksboers and Lammes and Anderson, showing reconstruction of the various parts of the heart in various findings. And you can see here at the end of the 8th week that there is really only a bicuspid tricuspid valve. The inferior leaflet has not yet developed. And on the right here is an echocardiogram at 19 weeks of gestational age. And you can see already the typical features of Ebstein's, the displacement of the septal leaflet of the tricuspid valve, the presence of tricuspid insufficiency, and an increase in the right atrium. And I think that we have to be cognizant of what the physiology is at this time in life. Because in the fetus at this time, the blood pressure, the systemic blood pressure, is about 10 to 15 millimeters of mercury. And during the course of development, the pressure in the systemic vessels and the pulmonary artery increases from 10 to 15 all the way up until 60 and 70 millimeters of mercury, placing a burden on the tricuspid valve during delivery, during gestation. Now, the previous speaker demonstrated this condition of the atrialized right ventricle and right atrium as part of the heart, and when this appreciated to a level of greater than 1 to 1 for the rest of the heart, the prognosis of the Ebsteins appeared to be impaired. And this was the origin of this paper that I wrote in 1988, 1989, it got published, of this prognostic thing that became the Sellermeyer index. And being such a small world, Dr. Sellermeyer's family is part of my family in Australia, so wheels within wheels. And here is a specimen where we've put that same atrialized right ventricle, right atrium. I'll use this example again and again, and I'll take the labels away so that you can see all of these things. And then 3 examples of Ebstein's malformation during fetal development. And you can see here the tricuspid valve is herniating, septal leaflet, and in this example as well, that the septal leaflet is malformed and rotated, and the anterior leaflet is large and sail-like, and this is a progression from mild to moderate to severe Ebstein's malformation. In this patient, the valve has been rotated so far forward that it's actually not visible, and this is all atrialized right ventricle. And tremendous increase in the bulge of septum primum into the right atrium. Now, the physiological feature of these patients that's important that I've alluded to is the development of tricuspid regurgitation. It can be mild, it can be severe, and it can be non-existent when the valve is entirely fused. So the variability to the Ebsteins from not only the displacement, but the valve may not delaminate at all and remain with a position of similar to tricuspid atresia. And we previously have heard of this circular shunt, which my fellows have called the circle of death. And here is that same 19-week fetus that was our index case. And you can see that there's retrograde flow in the arterial duct here, and that the tricuspid regurgitation, rather than coming from the annulus, is coming from way in the ventricle. So there's a right to left shunt, and there is also tricuspid regurgitation with corresponding increase in the size of the right heart structures and also involving the left heart. In the middle is a 38-week fetus that died with so-called pulmonary atresia. The ductal pressure had held this pulmonary valve in the closed position, and it then became atretic. And there's just a Botkin in there to show you that the valve is atretic. And the echocardiogram in the short axis shows what I've already alluded to. Here you can see the descending aorta and the right to left shunt. And lastly, the so-called circular shunt with the blood coming from the ductus and going into the ventricle through pulmonary insufficiency. So this is a cycle of physiological development. Increased central venous pressure and venous flow and development of hydrops occurs. The right atrium is dilated. The right ventricle becomes dilated and thin-walled. There's decrease in forward flow into the pulmonary artery, poor development of the pulmonary valve and artery, pulmonary regurgitation, development of the circular shunt, functional or real pulmonary atresia, pulmonary artery fluids retrograde from the ductus with more right to left shunting, poor ventricular function of the left ventricle with the, probably because of compression, ventricular-ventricular interaction, and the fact that Ebstein's malformation can be considered a cardiomyopathy and fibrosis. So that's how it goes. This is going backwards. I don't know what's going on with this machine. Okay, and then decreased coronary perfusion and cerebral perfusion and eventually death. But anywhere on the circle you get on, the whole circle of events occurs in Ebstein's. Now, I'll just bring out some of the things that we see with the ultrasound. Because the right ventricle is enlarged, it is frequently possible to see the right ventricle in standard ventricular views, like a parasternal view. And here's a specimen cut to show a parasternal long axis equivalent. And you can see the anterior, superior, inferior, and septal leaflets on a parasternal long axis. The right ventricle is enlarged, the left ventricle is compressed, and the right atrium is also large. And here is the echocardiogram showing the anterior superior leaflet, the inferior leaflet, and the septal leaflet plastered against the ventricular septum. This specimen comes from the Pittsburgh archives, was given to me by the late Bob Zuber-Buehler. And so this is in your archive over here and shows the position of the atrioventricular junction in red. I will not mention that again, but the AV junction is in red, and the displacement of the attachment is shown in green here. And the echocardiogram in that parasternal short axis shows the medial papillary muscle, anterior papillary muscles, so the anterior superior leaflet, the inferior leaflet, and also the septal leaflet, which is attached to the ventricular septum. You can see this from the apex. Here's a patient where we're looking at the apex of the heart in a normal, showing the medial papillary muscle, the anterior papillary muscle, and here's the posterior papillary muscle, so septal leaflet, anterior superior leaflet, and inferior leaflet. And all three of these can be seen on an apical displacement of the parasternal short axis plane. Now here are three comparisons between a specimen which shows the septal leaflet and the anterior superior leaflet. And note particularly these attachments of the abnormal anterior superior leaflet to the underlying ventricular myocardium. This was given to me by Dr. Justin Tretter, is an example of Ebstein's malformation. You can actually see the anterior papillary muscle here attached here with the shadow of the valve. You can notice that there's also regurgitation in this area here. And the mitral valve is in its normal position. What you haven't looked at, which I'm going to interpret for you, is that there's also spongy myocardium of this patient. So this isn't just Ebstein's, but a variety of Ebstein's, a number of them, have also spongy myocardium or non-compaction of the left ventricle. And I think puts us in the idea that what Ebstein's may eventually be is a form of a cardiomyopathy. And then the echocardiogram shows the apical displacement of the tricuspid valve. The septal leaflet is plastered against the ventricular septum. And here is this huge sail-like anterior leaflet with its caudal attachments to the underlying ventricular myocardium. So here again is that frontal picture corresponding to the echocardiographic plane. And you can see the annulus, the septal leaf, the inferior leaflet plastered against the myocardium here. So this is all atrialized ventricle. There's the true effective orifice of the valve and the regurgitation going down towards the apex of the ventricle. In no other condition does tricuspid regurgitation present itself in a diaphragmatic position. And the diagram of Christian Shriver, which we've shown you, showing this valve. Now, I've done this with pathology to show the junction and the displacement of the septal leaflet. And here the whole valve leaflet teased open with the septal and inferior leaflets being displaced in the anterior superior leaflet in normal position. But we've used this previous picture that we've shown you of the orthogonal subcostal equivalent and the coronal, that's the coronal, and this is the sagittal plane cut. And you can see here that we can look at the annulus in 2 dimensions and see that this annulus is displaced in space towards the diaphragm, the outlet of the ventricle, and that the jet of regurgitation is always directed at the diaphragmatic surface of the right ventricle. Okay. Now, I call Ebstein's disease the dozen Ds, but since working with the De Silvas, I've added another finding, and so I've made this a baker's dozen, which is usually 13. So displacement of the proximal leaflets we've discussed, dysplasia of the valve, distal attachment abnormalities, and dysplasia of the underlying myocardium, and dysrhythmias because there's no D in arrhythmia. Wait a minute, Simone, I'll let you take a picture in a minute. So let's go through that again. Dysfunction of both ventricles, both systolic and diastolic, dilatation of right heart chambers, arterial duct associations, which we've seen, deformity of the right ventricular outflow tract and pulmonary artery, which we've also shown you, defects others, such as ventricular septal defects and pulmonary stenosis. And now this is the 13th D, the 12th D is think De Silva operation when you look at this. And I don't mean that in some kind of a patronizing way, but what I think is important is that when you think of surgery today, you think of the De Silva operation, and you have to look at these hearts in the way that you can find and highlight these things for the operation. And of course, the last one that happens to all of us is death. And did you want that a picture? All right, I'll go back for you. Sorry. Very difficult to go back. All right. Okay, take a picture. Okay. All right. Are we all done? Okay, so now we're going to look at all of these things in sequence. So we're going to look at the displacement of the valve from its true position at the atrioventricular junction. And this gets worse and worse. So I've got mild to moderate, and severe displacement down towards the apex. And the displacement is because if you look at the right ventricle, the valve is moved into the outflow tract. So if you look at it in the long axis, you can miss it. In the 4-chamber view, you may miss the valve and see what looks like a very small amount of insufficiency right at this region here at the cardiac apex, because the valve is displaced into the outflow tract largely. And there's this famous paper that followed our description of Ebstein's malformation, describing an index of 8 millimeters per meter square of displacement. And I just point out to you that this variable, this is the same patient. Here it looks small, here it looks large, because this is the front section over here, where the septal leaflet of the tricuspid valve is minimally displaced to its point of maximal displacement posteriorly, which allows you to do this. So if you're going to look at displacement of the tricuspid valve, you must angle your probe inferiorly in order to see this in the four-chamber view and record it accurately. So this is the same patient, the same sweep that is done on the same woman a mother who was pregnant, and you can see that the displacement when you go back is much more than the displacement when you look at the front. So that's really an important caveat for the four-chamber view. And you can do the same subcostally, and you can see how the annulus rotates round, both on the specimen, which looks relatively normal, and you can see the anterior superior leaflet is fine, the septal leaflet is plastered against the ventricular septum, and here's the true junction and the annulus, and the mild, moderate, and severe displacement that occurs when you draw the annulus. And I've put the Schreiber diagram in there just to show you the variability of this rotation of the valve into the outlet chamber. The valve can be dysplastic. In fact, it almost is, as you've seen on many of the examples. And here you can see the so-called verrucous nature of the septal leaflet of the tricuspid valve. Here is the anterior superior leaflet, which is also thickened and rolled. And here I'm pointing out on this big sail-like anterior leaflet, the tendinous caudal attachments to the underlying right ventricular myocardium of this anterior leaflet, as well as the abnormality on the septal leaflet. And when that get really severe, this is a neonate born with a severe Ebstein's malformation and non-coaptation of the tricuspid valve, begging surgical treatment. Here's the anterior leaflet attached to the underlying myocardium with very little motion to that large anterior leaflet. This is just aortic outflow, but you can see that there's almost nothing happening in this ventricle. And here is the displacement of the posterior leaflet or inferior leaflet of the tricuspid valve. Here again is you'll see the displacement of the annulus over here, drawn in of the valve attachments, not annulus. And here's the AV junction here, and the septal and the inferior leaflets. I'll just take the diagram off. So you can see the sail-like and abnormal anterior leaflet, the septal leaflet and the inferior leaflet are seen there. Remember, when you're looking at a four-chamber plane, you cannot see the septal, the inferior leaflet, and you see just the septal leaflet attached to the septum here with severe tricuspid regurgitation, and also the attachments of the anterior leaflet to the underlying myocardium. Now, the distal attachments are also abnormal in this condition. Here is a relatively normal anterior leaflet, and here is a linear attachment of the valve leaflet to the underlying heart. And this presents a problem for the surgeon, which we can see to some extent, and that this rotational and positional abnormality of the distal attachments is variable rather on a spectrum of conditions than a particular milepost of where they occur. But I've just used these examples of Ebstein's to show from relatively normal to linear attachment, with this being so-called hyphenated attachments of the ventricular leaflets of the septal leaf and the anterior leaflet. So here's that first picture that I've shown you, and matched this with an echocardiogram to show the functional right ventricle, the atrialized right ventricle, the tricuspid regurgitation jetting towards the diaphragm. And here's another one. You can see more severe tricuspid regurgitation striking the diaphragmatic surface of the heart. Here are subnormal, what we call hyphenated attachments, 1, 2, 3, and these down over here. One of these must be the anterior papillary muscle. there's the anterior superior leaflet. So this is septal leaflet with its hyphenated attachments. And here is an echocardiogram matched to this specimen. This is from the UC archive, by the way. And you see the anterior superior leaflet in the outflow tract, and the inferior leaflet, seen best in the subcostal, coronal, and sagittal views, is attached here with hyphenated chordae attaching and keeping this valve from being mobile. And again, another example showing the hyphenated inferior leaflets, the atrialized right ventricle and the functional right ventricle, which is really quite small. Here are some hyphenated attachments of the septal leaflet, both to the free wall and to the septum, going all the way around there. And here is an echocardiogram that shows those attachments. And here's one which is a halfway, showing the hyphenated attachments and the linear attachments of this valve in the same patient. And here we can see all of those hyphenated attachments underneath the anterior superior leaflet that will be removed as part of the De Silva operation. And then, of course, we can have the case where there's total attachment of the tricuspid valve to the underlying myocardium, producing a so-called tricuspid atresia. And here is an echocardiogram of such a patient. You can see very little function of the right side of the heart here. And the motion of the valve is largely the motion of cardiac motion rather than actually of ventricular motion. So that's pulmonary atresia. And here, just to show you that can occur, here's a patient with pulmonary atresia, a young boy of 11 years of age, who also had isolated restrictive muscular ventricular septal defects, acting for this patient as a divine band, and he was actually living a reasonably normal life with a little bit of mitral insufficiency. But so you can have what looks like a normal prognosis with a clear Ebstein's malformation, but this is pulmonary atresia and only survived because of small muscular ventricular septal defects. Now, we talked about dysplasia, and here is an example of fibrosis of the underlying myocardium. This is looking at the diaphragmatic surface, and we're shining a light in the ventricle, and fibrous tissue transilluminates if it's thin enough. So that's an area of total fibrous replacement of the right ventricle, and would be also cobbled up as part of the De Silva procedure. And here's the echocardiogram showing you this apical thin area of the atrialized right ventricle in a live patient. So we talked about the pulmonary valve. You've seen this picture before. There's pulmonary atresia. At 20 weeks of gestational age, this patient had a beautifully normal opening of the pulmonary valve. But at 36 weeks, before the patient died at 38 weeks, this is what the motion of the pulmonary valve looked like in this very particular patient. So there's pulmonary atresia as a developmental problem, and one of the things to consider in this disease. So there are malformations that we know frequently affect left morphology, as we've mentioned, spongy myocardium, and the defects are invariable atrial septal defect, ventricular septal defects, pulmonary stenosis or atresia, and excessive trabeculations, which we formerly called spongy myocardium, Wolff-Parkinson-White, and of course, congenitally corrected transposition. So that's what I have to say, and I hope it's been useful to you. And I thank Dr. De Silva's, the two of you, for inviting me here today. And it's a real honor for me. Thank you.